Good afternoon, everybody. This is Monique Dever, the moderator for today's webinar. We're going to go ahead and get started in about 5 minutes. People are still logging in. I just wanted to make sure everyone was connected correctly and all that. So we're just going to put you on mute for a little bit longer, and we'll be back in about 5. Yep. Okay. Good afternoon, everybody. Thanks for joining our webinar on combating the opioid crisis using EHR, GIS, and wastewater sampling. My name is Monique Dever. As I mentioned earlier, I'm going to moderate the presentation today. So we have two presenters today. We have Mike Bajorek and Sonali Luniya. Mike is a civil engineer by training with a master's degree in business management and has served as the deputy town manager for Cary for over 30 years. He's currently serving as the project champion for their opioid measuring project. He's going to share some firsthand experience of the program he developed and is ongoing in his work today. Sonali is the co-founder and the VP of Customer Experience here at Patagonia Health, and she's got extensive research and development of electronic health records. Sonali will demonstrate how the healthcare agencies can use this data, for example, Mike's data that he's working on with the GIS and EHR systems to make informed decisions when it comes to fighting the opioid epidemic. Before we get started, I just wanted to mention that you will all be on mute during the presentation. We will open it up to questions in between the presenters. If you have questions, please go ahead and post those in the chat box. Those are on your right dialog box that can shrink and expand by that little red arrow. Anytime during the presentation, please just go ahead and type your questions in there, and we'll get to them throughout the session and then do the Q&A at the very end. So before anything else, do we have Mike?
I think that's good.
Okay. Mike, take it away.
Well, thank you. And good afternoon or morning, as the case may be, to everybody. It really is a pleasure and honor to get to talk to you today. For those not familiar with Cary, you know, we're a town of a little over 162,000 people, of highly educated and involved citizens. Sometimes I would say too involved. Cary is located right here in the heart of the Research Triangle in North Carolina, and is known for its tree-lined streets and well-planned subdivisions, beautiful office parks like what we're in right now, abundant shopping, and really a revitalizing downtown. Now, in addition, for well over the past 10 years, we've also been, according to FBI statistics, one of the top 10 safest mid-sized cities in the country. Also, we have an opioid problem. As with most things, before you can affect any change, you really have to acknowledge that there is a problem. You know, for us as an organization, that pivot point came November 28th, 2016. That was the Monday after the Thanksgiving holiday. I remember it really clearly. You know, we were in a department director meeting, and our fire chief walked in, and during the meeting, he reported that his folks responded to 5 overdoses over the holiday weekend, 3 of which were fatal from opioid overdoses. And so I'm sitting there and saying, opioid, is that heroin in Cary? And that started a series of discussions. Yes, that was in Cary, and it was heroin overdoses. In January of 2017, our mayor showed some great leadership when he stated in his State of the Town address that he was making fighting the opioid problem in Cary one of his top priorities. And he continued to say that while we may not be in crisis, last year we had 6 fatalities due to opioid-related overdoses and 40 additional drug-related overdoses. But what city was in a better position than Cary really to make a difference? So today, I'd really like to talk about a couple things. How we're using lessons learned from baseball 20 years ago to hopefully make an impact on the opioid epidemic here in Cary and hopefully North Carolina and beyond. You know, for full disclosure, I love baseball, and as my wife will attest, you know, everything important in life can be explained by using a baseball analogy. So So after the mayor laid down this gauntlet to say this was truly very important for him, our town staff just went out and talked with all sorts of public health officials, organizations that were already involved in the struggle. And we wanted to know how we could help and how bad of a situation out there. See, in North Carolina, cities, municipalities don't necessarily have a public health mission. That belongs to the county, but we wanted to be there. We wanted to help. Okay, maybe next slide. So what we were told really got us thinking. You see, the current data sets our public health professionals are using to gauge the extent of the problem and really develop their programs, I think it was really hampering their effectiveness. They were reactive, the number of overdose deaths. They were kind of static. It takes 6 months to a year to get an autopsy report to identify what exactly was the cause of death. Information they were getting were coming from questionnaires, and pretty much all of this was at the municipal level, aggregating data over large areas. And the results of using this data aren't great. You can see from the graph. And now, please note that this is in no way, shape, or form an indictment of those folks working in the field. They are doing a phenomenal job with the cards that they've been given. Next slide. And this is where the baseball connection comes in. You see, 20 years ago, there was a general manager for the Oakland Athletics named Billy Beane. And he was made famous by the book Moneyball, but he introduced data analytics and predictive modeling to baseball, and it really changed every aspect of the game. For us, through a series of seemingly random conversations and some solid research done by a number of our people on the Town of Cary staff, I was put in touch with a newly incorporated MIT Innovations Lab spinoff company named Biobot Analytics. And they developed a procedure to measure the concentration of various opioid metabolites in wastewater, and we're looking for a location to start a pilot program. In addition to the measuring, through a series of calculations, they have been able to calculate the amount of metabolized drugs consumed, as you can see on the slide, the different ones, both legal, illicit, treatment, and recovery, in number of doses per day per 1,000 people. While this is pretty cool, similar research has been done a lot in Europe and some in Australia. But what really makes Biobot Analytics process innovative is how they were collecting their samples. You see, whereas most of the current research has been done on samples collected from wastewater treatment plants that serve populations of 50 to 100,000 people and 8, 10, 12 million gallons a day of waste goes through. Our partner has developed a collection device that can collect samples from smaller, more distinct residential catchment areas with populations between 10 and 15,000 people. Now, these catchment areas are large enough to ensure the wastewater is totally aggregated and de-identifiable, but distinct enough where we can now add additional layers of information to the baseline chemical analysis. So think about adding to the chemical analysis for a particular area demographics, social, economic indicators, land use, the number of drug or grocery stores in the area, proximities to parks and greenways, and a whole sort of other parameters. So our goal is to place the chemical analysis along with these other data sets into kind of an open data platform to be easily analyzed by folks that are in the field. Next slide, please. There's a reason why managers coach from the dugout and not from the Goodyear blimp. You know, similarly, our discussion with public health officials have really been encouraging. You know, giving them proactive data sets in near real time has the potential of transforming how they develop and manage programs. You know, Billy Bean coined the phrase years ago, better data, better insights, more wins. You know, our vision for the program for this project is better data, better insights, more lives saved. And I think that really speaks to what we're trying to do. And I think this is the last slide. Yeah, finally, I just want to kind of give you a quick recap of where we're at with the project. See, back in February, we were named a champion city as a part of the Bloomberg Philanthropies Mayor's Challenge program. This also came with a $100,000 grant to help us implement the pilot. We hope to start the proof of concept sampling later this spring and implement the full-scale pilot this summer. In September, we will be applying for a second round of funding from the Bloomberg Mayor's Challenge with hopes of being awarded one of 4 $1 million grants or the grand prize of $5 million. Now, when we get the award next, got to think positively. You know, our vision is to really extend this program to other cities throughout North Carolina and perhaps the nation, both more rural and urban than Cary, to create a kind of a broader data set of information. You know, when we brought on several partners to help us implement the program, besides BioBot Analytics. They include multiple local and state public health officials, some data analytic and modeling groups from the Research Triangle Institute and the SAS Institute, which is right in our backyard, along with several citizens. Now, we still need help in really 2 distinct areas. One is help in citizen engagement. How do we best facilitate the conversation about opioid misuse in our community? You know, Sam Quinones, the article of Dreamland, the story of the opioid epidemic, and if you haven't read that book, I highly recommend it. It talks about the stigma associated with overdoses and how opioids are really the poster child of isolation. People aren't talking about it, so it just continues to grow and grow and grow. One of our goals with our pilot is just to get our citizens talking about what's going on. Parent to family, neighbor to neighbor, having the discussion of what this opioids are. You know, these are good drugs, but they can lead to misuse in certain areas. You know, just as an example, if I got time, my son blew out his knee about 5 years ago in college, and you know, the doctor gave him a jar of opioids, prescription opioids that probably was 2 inches in diameter, about 6 inches tall. And as like any good dad, I was pushing these things on him, saying, take them. The doctor gave him, and luckily he had the sense to say, no, I don't need these things. Just give me ibuprofen. As I now know, that is really the beginning of a cycle. You get a kid hurt in athletics or a person hurt at on the job. In order, they get prescribed these drugs, and then in order to get back to work or back to play, they continue to take these things. They run out, then they start stealing the drugs, and then that becomes too hard, and then they start buying them, and that's too expensive, and then they start using heroin, which is about as cheap as what you can buy a pizza. Nobody starts out thinking, let me shoot up with heroin. And then the next step, the final step is somebody laces it with some nasty stuff and they overdose. And then there's really a problem. So what we're trying to do is stop that cycle in its tracks before people are addicted through conversation. The second piece of this that we need help on is really we want to develop this open data platform where we can do data analytics, predictive modeling, data presentation. How will all this work? How will folks be able to add, extract, analyze this information and still have it all worked? We still haven't worked all this out. You know, this is one of the things that make working on this project so interesting. We don't have everything worked out, but we think that this really has an opportunity to be transformative, and we invite you to help us. We'd love to talk with you and see what you can do and how you can participate. You know, I think because together, I believe we can have a huge impact on the opioid epidemic, not just in Cary, but really around the country. And I invite you to come along for the ride. And thanks for listening.
Okay, thanks, Mike. That was a very good story. We're going to go ahead and turn it over to Sonali now, and she will take his information, give you his background, and then apply that to the EHR side of things and the data sets that Mike referred to. Sonali?
Thanks, Mike. I have no baseball story. I have no basketball story. I just have technology.
Yeah, but you want the basketball story.
So I wish I did. So good afternoon all. This is Sonali from Patagonia Health. I see quite a few users of our existing system are logged in. So quite a few attendees, I've met them in person and they've heard from me before. So here I am again talking about opioid epidemic and how electronic health records can help combat this epidemic that we have nationwide. So on the slide, you see some numbers about how big the epidemic is across the nation. This is directly from the CDC website. Quite a few of you may have already seen this, but I just want to preface the presentation with these numbers to put it in perspective how big the problem is across the country. Some of the numbers are really astounding. For example, 12.5 million people misuse the prescriptions in 1 year. And on the next slide, you'll see about 259 million prescriptions are written in 1 year just for painkillers. And 40 people die every day with opioid prescription overdose. So it is a nationwide problem, as we all know. We all are hearing about this in the media, in the news. And the nation is coming together. So, for example, the Town of Cary initiative is the nation is coming together or coming up with solutions of how we can combat this problem together. By the way, Patagonia Health is located in the Town of Cary. I don't think we mentioned that. So we are very happy to have Mike here, and we would like to help him in any way we can.
Yep, they're located in one of the town's beautiful tree-lined office parks. And if you're considering moving into a different facility, think about Cary. Sorry.
Sure.
You have to do it.
So to combat this epidemic, yes, electronic health records can help, which is technology can help. Thanks to the HITECH Act back in 2008, now EHRs are mandated in various clinician offices, in ambulatory settings, in hospitals, in public health departments, in FQHC, community health clinics, wherever. It is required by the federal government that you should be using an electronic health record system, which is good. Now that we all are here, and the recent statistics says a good 90% of the providers in the nation are electronic in some kind of form. Since now we are electronic, we have the resources or the mechanism available to take this to the next level and solve nationwide problems. And one of them could be this opioid epidemic. So in this talk, I will talk about various features and functionalities an EHR has to tackle this problem. One of the key features which can be utilized, and I'm sure several EHRs out there in the market have this feature where you can do electronic prescription of controlled substances. Electronic prescription is not a new thing. It has been around for a long time, for more than 15 years or so, and the adoption is very high. But that is generally used for regular medications. For example, amoxicillin or antibiotics or any other kind of regular prescriptions, they are done electronically and sent electronically to the pharmacy. electronic prescription of controlled substances is a fairly new thing, maybe in the last few years. And now it is, I think in the next 1 year or two, it is going to be mandatory in all states that controlled substances should be prescribed electronically as well, as in you write the prescription in the electronic health record and transmit it from the system to your pharmacy. There are many benefits to this. One, it helps with patient safety because it does drug allergy interaction checks, just like any other e-prescription system. If you do that for controlled substances as well, you get that drug allergy interaction checks done. It improves the accuracy because your prescriptions are a lot more legible when they go over to the pharmacy, since they're going through the computer and not on a piece of paper. It reduces fraud because they're transmitted electronically and securely. So if you give a prescription on a tamper-proof paper to the client or the patient, there's a possibility they could duplicate it and could get refills without really having a real prescription. So to avoid these kind of frauds or misuse or abuse of these prescriptions, electronic prescription of controlled substances is becoming mandatory nationwide. The sad part is the recent statistics, this is pretty recent, I think this was done last year, less than 25% of the providers across the nation are using electronic prescriptions for controlled substances. And they have good reasons. Why are they not doing it? It's because the whole process of how you get yourself set up for EPCS is a little cumbersome because the clinicians have to do an ID proofing done, they have to go through an audit, and every time they write a prescription, they have to have a special kind of passcode which needs to be entered for every prescription transmission, which is a little cumbersome and inefficient in their workflow. But given the benefits, it's really worthwhile for the clinicians to have this feature enabled and integrated into their workflow. So many EHRs, just like Patagonia Health, this is a screenshot from the Patagonia Health system, we do have this feature, and they can send prescriptions, and there are different ways they can generate the passcode. They could have a key fob, like a hardware, or it can be something that they can directly get it on their phone and just push it through the phone, and they can send the prescription out. Other features that can be used in EHRs to combat opioid problems is using the prescription drug monitoring programs. Many states across the nation, or I would say pretty much all states, do have PDMPs that are state softwares where information of all clients, if opioids or any controlled substances have been dispensed to all patients across the state, the pharmacies are mandated to send this information back once it's dispensed into the PDMP within 24 hours. In some states, it's 24 hours, some states it's a little longer. So it is a pretty comprehensive database where pharmacies have updated the RX or the prescription fill information into the system. So as a clinician, I could log into the system and see what prescriptions have been filled for this patient, which are controlled substances. And this information can come in handy to identify if this client is on any other medications, or if this client has been receiving medications from other doctors, or doing that, which is also called doctor shopping. And you get a complete history of the patient's prescription fill history if you can pull this up while you are in your EHR. Again, the use of PDMPs, which is where the providers actually go into this portal, the PDMP set up by your state to look up what the client's history is, it's only 14%. The usage is pretty small. Again, the statistics is pretty recent. It was done probably last year. So it's about 86% of the prescriptions that are written right now, the clinicians are actually not going into the state PDMP to identify or to get the complete picture of the patient's drug history. They have good reasons why they don't do that, because PDMPs, which are state software, they don't integrate into the EHRs directly. And many state systems, they don't integrate with other state systems. So specifically for the ones who are living on the borders of a state, and if they are going across borders, then you want to get data from both the state PDMPs. These state PDMPs don't really interoperate, or they don't integrate into the EHR. That's why the usage is low, since the clinician has to come out of their EHR screen, go to a different screen, and look up the information. There are other possible solutions. One of them is the SureScripts database, or many of you may have heard of this before. So the SureScripts database is a nationwide drug dispensing database, which is collected from all the pharmacies. So the pharmacies, again, when they dispense any kind of med, whether it's controlled or not controlled, they are supposed to update the SureScripts database. And within, I think, maybe 24 to 48 hours, and clinicians can actually pull up this drug history directly into the EHR. This is integrated into the electronic health record systems. This is a screenshot of what is in Patagonia Health. You can see on the screen, they can write when they are doing the prescription, they click a link, and the SureScript drug history of any patient shows up. And it also tells them when it was filled, at which pharmacy it was filled, and what their current medication is. So are they compliant? Are they doing doctor shopping? All this information shows up on your screen right away. The downside of SureScript drug history, it works only for insured patients, which includes private insurance, Medicaid and Medicare, or managed Medicaid. But it does not show this information for uninsured patients, which is available in the PDMP. So there's a downside to SureScript, so that integration into their state PDMP is really important for this epidemic specifically. But if you have a whole bunch of insured patients and a lot of your patients or clients in the state are on some kind of Medicaid system, you can definitely utilize this feature in your existing EHR system to get their information of any kind of opioids or benzos or any other medications that they are on. Okay. What else can be done? These are things that have been proposed at the federal level, where they are proposing to limit the quantity prescribed at the initial visit, and also to limit the doses that can be prescribed at the initial visit. So if these do go into effect, what does that mean? EHRs can help with providing alerts and warnings to the clinicians by warning them that either you're prescribing over the recommended limit, or the doses you're recommending is higher than what has been proposed or what you should really be following. So this is coming down the pike. EHRs are not there yet, but this is being proposed at the federal level to put limits on the quantity prescribed and make EHRs give these alerts and warnings to the users. There are other things that EHRs can do is beyond just writing prescriptions or monitoring the drugs. There are other things EHRs can do to identify if the patients really need these medications. So there are different clinical tools to identify if clients are actually at risk. Do they have any other behavioral problems, or do they have any other living problems which are going on in their life, to identify how at risk are they, and if they have to be given opioids, what dosage levels should they be given at. So some of these tools can be integrated into the EHR, and these are some screenshots from the Patagonia Health system where we have patient-centered assessment. So these tools help identify other problems. For example, if they have anxiety issues, for the generalized, the GAD-7 is a common one, the anxiety disorder scale, or you can do a PHQ-9 or a PHQ-2 to see if they have depression problems, or do a DLA, which is their daily living activities, to identify if they have any other issues going on in their daily lives. So these scales these are assessment tools. The system can actually capture all the data from the client and then score this information as how are they doing on these scales, to identify how much of a need do they have for any kind of opioid or any kind of controlled substance prescription. Also, they can identify at-risk individuals. So for example, this is a COW scale, which is the clinical opioid withdrawal scale. So if you have existing patients who are on opioids, and when they come back in and they show some symptoms, you can watch the symptoms and put this in the COW scale to identify, okay, are they showing any withdrawal symptoms? So next time, if I'm going to write a prescription for this patient, should I taper the dose or should I increase the dose? So it really helps in identifying what dose levels and other clinical decisions that should be made if they're showing any kind of withdrawal symptoms. These on the left-hand side, you can see these scores. If they are done over a period of time, they can be displayed in a grid to see how the client performed over a period of time. So that again helps the clinicians make decisions of how they are doing on these various assessments or issues that or symptoms that they show when they present themselves at the clinic. Now this is about how to make clinical decisions. Now you've done your prescriptions, you've done assessments to identify what kind of clients who actually need help. Now you go ahead and write your prescription. What do we do next? Next, we want to keep track of these patients. Since now this information is electronic in the EHR, I should be able to run reports to identify who are the clients who have been identified with some kind of opioid use disorder, or they have been given some kind of opioid prescription, and I want to follow up with these clients. So if you get a report from the system, which you can export into Excel or you can export into a PDF, you can either follow up with these clients with a phone call, or you can actually send them text messages, and that's what we have on the next screen. You could send them text messages or send them email messages, which are more about educating them of either have a follow-up appointment set up or ask them how they are doing on their opioid prescriptions. Are they compliant? Are they showing any symptoms? And if they're doing better, maybe the dose can be tapered or it can be lowered. Or you can also send them other videos or handbooks or education material via email so that they can watch that to see how they can reduce the dependence on opioids. So this is the power of having the information electronically and having technology in your office. Since now all this data is electronic in the computer and it's not on paper charts all over the place, you can pull these reports out and have your EHRs. This is a functionality we have in Patagonia Health where you can customize your text messages and emails that can go out to your clients for education purposes. So this is at the individual client level. What can we do to reach out to them and educate them more? At an organization level, if I wanted to see, as an organization, I want to see where all my clients who have been diagnosed or have some kind of opioid prescription, where are they coming from? So I can take that report that I showed you earlier and plug it into a GIS tool. This is what I have on the screen. And it can show you, based on that information, where are my clients coming from which areas of the city or county are they coming from. And the GIS tool does a good job of clustering them all together. So it can tell you, oh, from this zip code, you have maybe 5 clients, and maybe from this zip code, you have 10 clients. So that's the power of having these GIS tools. That helps you identify where are the crisis areas in the county that I reside in, and where should I go out and do outreach, whether it's outreach for clients or it's outreach for providers, of teaching them how to do opioid prescriptions, etc. The beauty of GIS tools, and this is what Mike was referring to earlier as well, I can take the same information and overlay other layers. That's what the county GIS tools have. They can show you, and I have an example here on the screen. The black dots are the solid waste management collection sites, and I can overlay with that with my patient information, or maybe the information that I get from the biomass analytics, which is the lab data from the wastewater samples. I can take that and overlay it together to see where are my clients coming from, or overlay another layer of where are the schools, or where are certain demographics in the county. So having this information together in electronic format and having these tools integrated in various systems, either into your electronic health record or into your county tools itself, you can use this data to do further analysis to come up with an action plan of how you could combat this epidemic. Okay. So there are some references listed on the screen. These are pretty standard websites, CDC and the Health IT government website. If you need more information of any of the material that was presented today, feel free to review these links. And I think with that, we are open for questions.
Thank you, Sonali. Let's check the question panel. If anybody has any questions, you'd like to type them in. We do have questions. I may have missed this in the last few comments, but is Patagonia now capable of prescribing controlled substances through the EHR?
And the answer to that is yes. Yes, we do have the capability of doing controlled substance prescriptions and transmission of controlled substances through the EHR.
So you were talking about the 14% of providers using the PDMP system. Do you think maybe it just is an ongoing kind of a policy in-house if they're not doing it, maybe it can implement a new workflow process or something that may be able to help drive those numbers up?
Yes, there is lots of outreach and education that is going on after the opioid epidemic has become a nationwide problem in the last few months, where they are encouraging more and more the providers should actually access the PDMPs. And the PDMPs also have become more active of integrating their system into EHRs.
That would help your goal of getting help on your needs as well too, Mike. So if an agency out there doesn't currently have a GIS tool, I know several of the Patagonia Health customers that are listening today may have our GIS tool already, but what can they do for community outreach and planning if they don't have that capability to overlap the map, as you showed on the slide, like reports or such like that?
So if they don't have that tool in the Patagonia Health system, or if they have any other EHR system, the first thing is they want to make sure that this information is captured electronically in the right format in the electronic health record. So for example, if you're actually doing prescriptions, the prescriptions are written electronically from a prescription module, not pre-texted in some visit note. That cannot be reported on. Once that is done, then being able to run reports from your system for specific drugs or specific diagnoses, and then getting those reports out in Excel. Now, once you have them in Excel, you can just look up all the zip codes to identify the basic minimum you could do, just segregate your patient population by zip code, because zip code information is available in the EHR to see where are your patients coming from for certain diagnoses in certain zip codes. And the ones who are heavy on certain zip codes, I guess that's where you do your outreach first.
A little more data research. So, okay, and then we have another question come in. What is the cost to conduct the water analysis described? I serve in a small county, 25,000 population. So what is your experience in that, Mike?
Well, I think it's probably better addressed by one of our partners, Bot Analytics, that are doing that. But my understanding is right now they're looking at it's $18,000 for a series of tests for an area. So how big of an area, how many times? I think those are those questions that they would need to. But currently right now it is pretty expensive because they're still trying to have this system put into place and kind of try to understand what needs to be put in place to make this transferable, repeatable. So a little more expensive on the front end. That is one of the reasons why we are blessed to get the support of Bloomberg Philanthropies, so that not only helps us implement, it also makes it much easier to sell to our citizens that we're not using their tax dollars to do this right now.
So does for your $18,000 number of testing that they're doing, are they doing it at one site or is this at multiple sites now? Because you had mentioned it.
Our program is going to be our pilot is set up to have 10 catchment areas within the town. Now, initially, we're going to be doing 3 areas to really do this proof of concept, to do multiple tests in a few areas to make sure that we're getting the same results back, to make sure that everything is set. Once we get past that hurdle, then we'll be going to, we've identified about 12 catchment areas that are 90 to 95% residential. Another just hydrological issue is the waste needs to be in the system less than 3 hours. So to get the most of the metabolites to be registered. But I think we'll probably end up having 10 catchment areas.
Okay, thank you, Mike. Is there a way to predate an opioid prescription? For example, you may want to predate buprenorphine thank you, prescription for a patient who comes in for follow-up but still has BUP pills remaining. So predating the prescription can keep the patient from having to return to the clinic just for the prescription. Sonali,
Yes.
can you answer that?
Yes, you can predate your prescriptions in the EHR in your prescription module. It's used for two purposes. One, to write the prescription itself, and the second one is to enter information of existing prescriptions that the patient has and when it was written and how many prescription pills were written in that prescription with a previous date. Yes, that can be done.
Okay, and the next question, thank you, Sonali. Are the PDMP and EHR data set up to interact with the GIS through a web application? And are there any dashboards set up to make the data more legible?
So the EHR data set that we have, whether it's medication diagnosis, or lab results, etc., that is definitely already preset. The GIS map that I showed you is actually from one of our Patagonia Health customer accounts, and it was based on diagnosis. It can also be done based on lab results. The same information can also be done based on prescriptions that were written. So that's one aspect of it. Regarding your PDMP data, yes, the PDMP data, if we do actually interface with the PDMP, that information will get imported into the EHR system. And once it's imported, then it's ours for us to utilize it into the GIS tool.
So in addition to the opioid issues, GIS can be used for numerous other.
Yes, it can be used for numerous other diseases or problems or issues that you have and you want to solve them at the population level. One of the other usages is using it for tobacco cessation purposes to see where all your smokers are coming from. So information is charted in the record of if they have a smoking problem, and then that can be integrated into the GIS to see where your smokers are coming from. It can also be used to see lab results to see where all your gonorrhea or chlamydia patients are coming from or where your HIV patients are coming from. If they have been tested positive for any of these labs, that can be pulled into the GIS to map them to see the cluster of patients where they're coming from.
Okay. Mike, do you have any questions?
No, I just appreciate the opportunity to share what we're doing and be glad to offline to answer any questions or people want to see if they can help us out. I'm more than happy to talk with you.
So we have another question. Are the PDMP,
We just went
to that question.
over that.
Okay, so we don't have any other questions coming in, but we're going to hang out for a couple more minutes if anybody is in the middle of typing a question. Sometimes it takes a few minutes there, so feel free to go ahead and type in your questions. The information up on the screen at the moment is both Mike and Sonali's contact information. If you have questions, feel free to reach out to them. The webinar can be, the recording of the webinar can be accessed through the same link that you registered for the webinar probably by tomorrow. So if you'd like to watch it again or share it with colleagues, then that's will be available for you. And I think you're probably going to get an email from GoToWebinar that says, thanks for attending, here's the link. So if anybody doesn't, don't see any more questions coming in. So thank you very much for attending today. It's been kind of an overwhelming response, so we may be scheduling it again in the future, but we'll of course let you know. And we do have a couple other webinars coming up, but we don't have those scheduled yet. So keep an eye out for future topics. And if you have topics you want to hear more about, then you can send those requests in as well. So Mike, Sonali, thank you very much for presenting today.
Thank you.
Attendees, thank you for coming today. Appreciate your attendance, and we look forward to serving you again in the future. Thanks very much.
Thank you.
Yeah,
Bye-bye.
thanks a lot.
Bye.